Oh,
Oh, sorry. Good afternoon. My name is Mike Diachenko, and I work with Optimus Technologies. Today, we're presenting the final webinar of our five-part series on MIPS 2017. Today's webinar is going to focus on an in-depth look at the improvement activity category. Just to note, for those of you who have sat through my ACI and quality detailed reviews, this one will not be as complex due to the nature of the category itself. There isn't a lot of settings in CPS that we have to view or data validation, really. So this is more going to be geared towards improvement activities, which, are kind of outside of CPS itself. So for today, the overview of the presentation, first we're going to start with a review of the improvement activity category. So kind of, what the category is, the scoring, that kind of thing. We're then going to cover 6 improvement activities themselves. So 2 high and 4 mediums. These are, recommended ones or ones that we've seen a lot of practices be able to do, or they're already doing them, so they can just take credit for them. Then we'll go over some activity selection advice and audit preparation. So if you're looking at activities that we're not covering specifically in this presentation, this will just help you determine how to select them and that kind of thing. Lastly, we'll touch on how the improvement activity category is reported, because it's a little different than the other categories, and it bears mentioning. And then finally, we'll show you some references and resources that you can look at. So again, we're going to jump into the improvement activity category. As with the previous category deep dives, we're going to focus or pretend that we're doing the 90-day full reporting track. It's the easiest way to illustrate the category. So the improvement activity category is 15% of your final score for the MIPS 2017 program. It's interesting how they calculate this. So basically, you have to get to 40 points to get the full improvement activity category. Each activity has a different weight. So it's either a high weight or a medium weight. High weight activities are worth 20 points. Medium weight activities are worth 10 points. There is no low designation this year. They may add them in future years, but it's looking doubtful based on the information coming out of CMS. There's an important note to this, that if you are a practice of 15 providers or less, your activity weighting is doubled. For example, if you're a practice of 12 providers and you do 1 high activity weight, you've met the full category requirement. If you're more than 15, so 16 plus, the weights that are listed there are what they're going to be for you. Now, there's an important designation there because you don't have to report as a group for this reweighting to apply. It's based on the size of your practice. So even if you're reporting individually and you're a practice of 7 providers, all 7 of those providers are going to get the double weighting, basically. So it's a little strange because of group reporting and then small groups, but I just wanted to point that out there. You don't have to report as a group to get this reweighting. Important thing to note about the improvement activities is you're very likely already doing some of these, enough of them to pass your improvement activity category. So after this presentation, when this is published, we'll also be publishing an Excel spreadsheet that I put together that goes over all of the available improvement activities. It's not much different than the QPP website, so what's provided by CMS, but it's an easier way to look at it, and it has a couple additional fields that are helpful all in a single file instead of having to go through the website and then checking other resources. So the improvement activities themselves, there are 93 approved for 2017. 14 of them are high weight, 78 are medium weight, and then that 1 where the numbers don't add up is for PCMH certified practices, so the patient-centered medical home, which is a NCQA program. That doesn't really have a weight, but if you're a PCMH certified practice, that counts as full improvement activity weight. So you get the full category without having to do any other activities. We should expect more in 2018. Last I checked, because the rule just came out, they're about 112. So they've added some. It doesn't look like they've taken any out, but don't quote me on that. Just make a double check, but it looks like they're just adding more as the years progress. And then there's a little reminder there that I beat to death on the last slide, so I won't go over it again. Just so you know, the activities are grouped into one of 9 subcategories, which are listed there. There's no subcategory requirement, right? So you don't have to do like, you know, one from one category and one from another one. You can theoretically do 4 medium weight activities all under the same subcategory and get the full improvement activity points. The reason why I wanted to show it is that it's going to explain how CMS labels these improvement activities, right? So when you're looking it up on the CQR, or if you're trying to look it up on the CMS website, it's always IA underscore the abbreviation of whatever category it is, and then the number. So some of these categories have up to 20 activities under them. Others are just 1 or 2. But it's important when you're looking it up to kind of understand where they're getting those letters from. As a scoring reminder, the improvement activity category is 15% of your total MIPS score. So it represents up to 15 points of the possible 100 points you can get for MIPS. It is not all or nothing. Nothing really in MIPS is, except for the ACI base score. But it's important to point out, because this one kind of gets underplayed a lot. You could theoretically, if you're a practice of 12 providers and you only have 1 medium weight activity you've attested to, and you do, it's not like you don't get anything. You get half of the 15 points or 7.5 points. But I want to reiterate, you should still try for all. It's attainable with a little bit of research. It's much less technical than the quality and ACI pieces to look at what the measures are and how to report them. And like I said, you're probably doing enough to get the full credit. So it's worth taking the time to look and see if there are enough out there that you're currently doing to get the full credit for the category. So now we're going to jump through some recommended measures. I'm going to do the 2 high priorities first, followed by the 4 medium weights. These recommendations are kind of based on our experience with past clients, and what we've seen are kind of overarching workflows that exist in CPS or in practices already. Like I said, there's going to be an Excel published with this presentation that will outline them all in a single spreadsheet. You can also go to the QPP website there to look at them now. The first one we're going to look at is improvement activity, EPA _1. So that's expanded practice access subcategory. And what it's looking for is you provide 24/7 access to eligible clinicians or groups who have real-time access to the patient's medical record. This is a good one to target if you do it, because it's available as an activity you can attest to through the CQR, meaning it is available for those 10 ACI bonus points. Kind of a description of the measure summarized is that these are really kind of 3 separate definitions. So if you fit any one of those 3, you've met the improvement activity. Where providers or the practice is available to assist patient outside of normal business hours. You have 24/7 on-call coverage. Whoever the on-call person is has EMR access. What I mean by that is they have the ability to log in and view the patient's full medical record, no matter where they are when they get called. Also, like official arrangements with urgent cares and the ability to instruct a patient off hours to go to the urgent care would count. The easiest one to really illustrate it is that on-call coverage though, right? So the patient calls practice off hours, is directed to a provider that has access to their chart. The provider can then give the patient instructions to either go to an urgent care or come into the practice the next day. The important thing here, and this is not for the attestation process, but for the audit preparation, is that you'd want to be able to have that call noted in the EMR via phone note, either at the time they take the call or the next day that they took a call off hours and what they instruct the patient to do. That way, if CMS asks for proof, you can take a screenshot and send it to them. So suggested documentation for preparation for the audit is as follows. Each one of the measures we go over is going to have a section like this. I cover this again at the end, but it's important to note now. The suggested documentation is cobbled together from various medical academies and physician advocacy groups. They're not expressly published by CMS, so it may be a little overkill, right? If they didn't get a solid answer from CMS, they most likely fell on the side of caution. So I'll go over that again at the end, but I did want to point that out. So some things you may want to have if you are selecting this activity is a policy on file related to your on-call or access, right? What's the callback time supposed to be? When are the calls supposed to be notated in the EMR, right? If you have an arrangement with an urgent care, what's that arrangement? If you have off hours, practice hours, what are they? Where's the location? How are patients alerted to this? Things like that. You'd also want to be able to, and this is more of the err on the side of caution, present hard examples. So there's an or kind of between each one of these implied, right? So the ability to screenshot a phone note from the patient's chart indicating that a call was taken outside of normal business hours and what the instructions were. Or the ability to show a bill code placed out of normal business hours for a service provided. That phone note doesn't necessarily have to be done at the time the call's taken. It can be done the next day as long as it's noted that it was an off-hours call and what the time of the call was about. The next one we'll look at for a high priority is engagement of new Medicaid patients and follow-up. This is not eligible for the ACI bonus, but it is still a high weight activity. The exact activity wording, because this one's nice and short, is as follows: seeing new or follow-up Medicaid patients in a timely manner, including individuals duly eligible for Medicaid and Medicare. What this really means is that you have Medicaid patients in your practice, right? So if you don't take Medicaid, you can't do this one. Timely isn't defined explicitly by CMS, but the general consensus from the various sources I use to compile the documentation requirements or suggestions is within 10 business days of the patient's request, you offer them an appointment. So they don't necessarily have to have taken that appointment, but that you had an availability to see them within 10 days of the request. If they don't take it, you need to have it noted that the patient was offered an appointment and they refused it, or if they wanted a different one. So an example of a way to help facilitate this one is if you have maybe pre-blocked appointment slots available for emergency visits that are open to Medicaid patients, excuse me. So again, the suggested documentation for an audit prep, you'd want all of the below, right? So you'd want a documented policy indicating that you can and do accommodate these visits in a timely fashion, whether it's through pre-block slots, double booking, you know, whatever you do when a Medicaid patient calls with a request for a timely appointment. You'd also want the ability to report, and you'd want to show multiple dates in your reporting period. Statistics related to when the request came in and when the first appointment was either offered or scheduled. So just a couple examples, you know, maybe for, you know, a shorter period of time inside there, but you want to be able to prove that you do in fact do it. You don't just have the policy on file. The last part of this that is not easy to deduce from the description of the measure is that you want to use the statistics you have related to this and the policy you have on file to help improve your availability for Medicaid patients. Right. So if you find out that you only have a 50% compliance rate and a 10-day turnaround, that you've made some sort of attempt, a documented attempt to either expand the available appointments on short notice or things like that. All right, so you take what your policy has found and you're working to improve on it. Right? Category is called improvement activities. The next recommended improvement activity to take a look at is a medium weight. And this is practice improvements for bilateral exchange of patient information. This is an ACI bonus eligible activity. An important designation here, right? So we had the 24/7 access one, which was high weight, was ACI bonus eligible. This is a medium weight ACI bonus eligible. When it comes to those bonus points, it's agnostic to the weighting, right? So if you do this one and you report it through the CQR, you still get 10 bonus points, even though it's a medium weight. If you have the transition to care configured and you use it, you're already doing this. So you see the summary of the activity description is ensure bilateral exchange of necessary patient information to guide patient care. Participation in a health information exchange, which is the method transition to care use, is doing that. Another option, if you don't do transitions of care, is that you have structured referral notes that are sent to the other provider, right? So on the next slide, you'll see here some examples. For our suggested documentation, you want to be able to kind of prove that you do, in fact, do this. So the easiest, right, is if you do send transitions of care, you can take screenshots of the transition of care, documents in the patient's chart, if requested, right? You can prove that you're connected to a health information exchange. Or if you're not doing the transition of care method, you want to make sure that you have those structured referral notes that are sent to the other provider in the patient's chart, right? And then you can screenshot it or whatever in the event that CMS asks for proof like that. You'll probably want a policy around either of these, right? So what are the timeframes we look at for that follow-up? You know, how quickly do we send that information to the other provider? What other steps may we take? Do we call, right, after we send it to ensure they received it? Things like that. The next one we're going to take a look at is also a medium weight. This is use evidence-based decision aids to support shared decision making. This is also a medium weight activity. This one is not eligible for the ACI bonus. What I mean by that is basically you can't attest to it through the EMR. It's a strange designation. You still attest to it through the CQR. It's just not eligible for the bonus points. So if you do this already, this is a simple activity to achieve. It's basically the description of it is right there. It's another short description, which we love. Use evidence-based decision aids to support shared decision making. So the use of things like algorithms, scoring or assessment tools, protocol-based checklists, or other standardized tools are what they're talking about. If you use any things like that in your practice to care for patients, you're doing this activity. You do want to make sure whatever tools or decision aids you're using are peer-reviewed and nationally recognized, right? That fits the evidence-based definition. So you can't just like make something up for just your practice. It should be recognized in your specialty or from a national organization. So the suggested documentation is kind of dependent on what type of tool you may use. So some examples are, you know, if you use form-based scoring tools or checklists, like a fall risk assessment checklist or a PHQ-9 checklist, screenshots from the EMR of that form in your system. You may also want to ensure that they translate into the notes so that if they ask for a patient example, you can grab a patient who's had that done and take a screenshot of the text in the note showing that it was actually used. You can also use things outside of the EMR for this particular improvement activity. So even if you use like paper checklists that a patient may fill out while they're in the waiting room. An example that we have here is a rapid-3 calculator for it's a rheumatology scoring tool. So even if the patient is filling it out outside of the EMR, as long as you scan it into the EMR and you use whatever they filled out to help drive your assessment and the care for that patient, that still fits the requirement. Also, if you're using policies or algorithms, right? So you just want to have those documented, where you get them from, how you use them. So while not expressly specified by any of the organizations that I reviewed to see the documentation suggestions, in general, I suggest you have a policy related to any improvement activity that you're going to select, right? So not only proof that you do it, but the policy that says when they're used, how they're used, that kind of thing, when they went into effect, right? How long have you been using them? The next example we're going to use is the implementation and use of specialist reports back to referring clinician or group to close referral loops. This again is a medium weight category, very, very similar to the one we just went over about the specialist notes, or the bilateral exchange of patient information. This is not eligible for the ACI bonus, but it's still, if you do it, a relatively simple measure to select and attest to. If you're a specialist, this one is probably more likely something you do and document. So having basically the regular practice of sending specialist reports back to the referring physician. If you're a PCP, it's a little bit more difficult to kind of fit what the activity is looking for because you need to have some sort of regular request or process to specialists you've sent patients to requesting that specialist report. What I mean by it being a little harder is that this needs to also be noted in the EMR. So if you're a specialist sending a note, whether you generate a letter or some other activity, you probably record that in the patient's chart. If you're a PCP and you're just looking for the specialist report, you more likely have to go out of your way to notate in the EMR that you've done that request. So some suggested documentation here. Again, it's a bit of a broken record, but you'd want examples of your specialist reports in the EMR that are sent to PCPs. So with a note of when it was sent, and a good example of this is if you do like a follow-up letter that gets sent out of the EMR and you save it to the patient's chart, right? That's it, right? You have the letter there in the patient's record. It's a permanent part of the record. It's got the date that it was generated. Or if you're a PCP, examples of requests sent to a specialist requesting the report. Again, that's a little bit harder to notate, but one thing you may be able to do to kind of skirt around that is scan in or load in the specialist report in the EMR when you receive it, and just record or notate the date that it was received from the specialist. Possibly at the same time, if you want to really, cross your T's and dot your I's, the date that it was requested as well. The next is very similar to the other decision aid, right? So there's a kind of a reoccurring theme here that some of these improvement activities really align with each other. So if you do one thing, you might actually be doing two improvement activities depending on how you go about doing them. So this one is the use of decision support and standardized treatment protocols. It's a medium weight. This one is ACI bonus eligible. And again, it's very similar to the evidence-based decision activity we went over prior. By that, I mean it's simple if you already do it. The exact measure description is use decision support and standardized treatment protocols to manage workflow in the team to meet patient needs. So things like checklists, algorithms, protocols that are used by the team to help guide patient care meet this measure. The only real difference between this particular activity and the one we previously discussed, BE12, is that this has to be in the EMR. So that other improvement activity, you could use a piece of paper the patient fills out in the waiting room, and you scan it into the EMR and you just use that data, right? That meets BE12. To use this one, these things have to be built into your system. So if you think about it, it's very similar to the clinical decision support that was a meaningful use measure. So in this case, again, broken record, suggested documentation for an audit, right? Screenshots from the EMR showing these tools incorporated into the EMR. If you have a form like a PHQ-9 calculator, take a screenshot of the form in your encounter set. If you use the protocols area of CPS, take screenshots of that. Another thing you may want to have, and I didn't note it here, but it should be implied, we can add it, is you may want to have the ability to show a chart note where these were filled out on a particular patient. You know, and that's kind of just, again, crossing your T's and dotting your I's. Another thing to have, and again, this is one of those places where it wasn't expressly spelled out by any of the resources I used to compile the documentation suggestions, but again, having a policy on file about how these are used, when they originally went live, how frequently you may use them to help do the assessments, that kind of thing. So those were the 6 recommended improvement activities. This one I want to go over specifically. So this is the special case, the patient-centered medical home designation. This is not ACI bonus eligible, but it's full credit, right? So if you are a PCMH accredited certified practice, you don't have to do anything else for improvement activities. You just have to tell CMS you are. You'll want to make sure that you're up to date on your certification. So you can, if you don't know, you can reach out to the NCQA, who's the accrediting organization for the PCMH designation. They can give you a letter or something. You probably have your acceptance letter. In general, the certifications are good for 3 years from the date of certification. So if you've done it recently, you can feel pretty confident, but I would just double check, make sure you're up to date on that. This is really an option for just PCPs. PCMH is a primary care designation for the most part. NCQA is planning to release specialist versions. That says in the coming years. It's been on the way for 2 or 3 years, so it could be at any time. But for now, this is really just something PCPs can look to. So if none of the 6 improvement activities we outlined prior apply to you, or not enough of them, and you're not a PCMH certified practice, how do you go about selecting a different improvement activity? Well, the first step is to go through the full ACI list. So you can either go to the qpp.cms.gov website, navigate over to their improvement activities area and take a look at all of them through their website, or you can use the associated Excel document that's going to be published with this presentation. The way that I would go about looking at them and kind of cutting them is, one, find out, you know, if you're already meeting one of the mediums that we went over and you've selected that and you're a practice of 16, then you know you need 1 more high priority and a medium, or 3 mediums to get the full credit. So the first thing you can do is sort that Excel spreadsheet or search the qpp.cms.gov website by just high priority or just mediums. So you can kind of have a smaller subset to take a look at, because it is quite a lot to review 92 all at once. While you're doing that, you may want to focus on those that are ACI bonus point eligible, because that's just, you know, a free 10 points for ACI. You know, so I suggest if you can, you select one of those. So always try to go for the full improvement activity category. That's 15 points. Like I said, it's relatively easy to get the full credit here compared to some of the other categories, which are really data-driven and provider-driven. This is more practice policy-driven. Also, if you do these activities, you attest to them in 2017, and they're things you really do and you keep up with, you can use them for 2018, and you can go into 2018 knowing that you're on solid footing. You have improvement activities locked down. You can then switch your focus over to quality and ACI improvements. Like I said, you likely do enough today to meet all of the to meet enough activities to get full credit. So a few hours of research is worth it if you can bank these 15 points. In general, audit preparation. So part of the reason why I went through the documentation suggestions or recommendations for each of the 6 improvement activities we looked at today is to give you an idea, even if you can't select one of those 3, what what they may be looking for, right? So the general rule of thumb is a policy or documentation on file about how you meet that activity, right? So again, this isn't written for CMS. It's supposed to be written as a practice policy. So, you know, our on-call coverage has Citrix access to CPS. It's one of our 6 providers. They rotate every week, blah, 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 right? You know, we expect callbacks to patients within an hour, 30 minutes if it's an emergency. If it's an emergency, we follow up with whatever organization we've sent them to, things like that. You also may want to be able to provide screenshots or examples in the EMR or elsewhere of the activity being done at various times during the reporting period. So for the 24/7 access, right, a couple of phone notes that show that you took a call off hours. Or for the coordination with the other provider, right, examples of specialist notes in your EMR that were sent out to the other provider. If you do an activity that's reportable, reports are awesome, but that's not always the case. A lot of things are not reportable in the improvement activity category, and it's not a requirement really for anything. So another kind of reminder here, these documentation suggestions were compiled from non-CMS resources, meaning these aren't official requirements from CMS. So you may be okay with less. However, if you've ever been through an audit with CMS before, you know the general rule of thumb is kill them with documentation. The more you send to them, the more likely they are to check you off and move on to the next group. A little disclaimer here, I just wanted to put in, which really just expands upon what I just said, so I'm not going to go over the whole thing again. And it's a disclaimer in a strange sense that I showed you what would certainly stand up to an audit. And the disclaimer is more, if you can't provide all of that documentation, you may still be okay with the testing to a particular activity, due to the fact CMS didn't really specify anywhere and clearly what they're going to be looking for in the event of an audit. So we'll kind of wrap all this together with how you report improvement activities. So all of that stuff about what kind of documentation you want to have on file, screenshots, all of those things, that's all audit prep, right? You don't need that to attest, right? You should have it in case you get audited, but the attestation process is literally a checkbox, right? So in the CQR, you just say, yep, that's one of the ones we do. This is the provide 24/7 access. It's a high priority, so you see it's 20 points, and you'll see that it's ACI bonus eligible, right? So you check it off. You check off whatever others you need to get your full credit, and then you do save selections. When it comes time to attest, those numbers are going to go with your submission. If you report via registry, the registries I've seen are very similar to this layout. You literally check off the measure that you do, you save it, it gets sent in with the rest of your numbers. The fail-safe reporting mechanism that applies to improvement activities is the CMS website attestation, which if you've ever done meaningful use, will be very similar to that, right? You log into CMS to a website they've yet to publish, put in whether you're a provider or a group, so you either put in an MPI or a TIN, and then you'll just manually check on a website, yep, we do this, right? So they're not looking for numbers with this, they're not looking for anything, it's literally, yes, we do it. So here are the resources that I've been hammering home over the series of these 5 presentations. But again, I just like to point out that they are very helpful. CMS did a good job this year compiling a resource library that's actually useful and effective. It's no longer just looping you back and forth between different web pages that never actually answer the question or use the dreaded word in its own definition, like transition of care. The definition of a transition of care is when you transition the care of a patient from one provider to another. So these are actually really helpful. But that is, at the end of the presentation. Like I said, the improvement activity category isn't quite as complex or in depth as ACI or quality. So it's really, the focus should be policies, documented, and ensuring that you do these activities at least periodically, that you can improve, prove in the event of an audit. But again, the attestation process is just saying, affirmatively, yes, we do this. So that is the end of this presentation. It's also the end of our MIPS 2017 presentation series. We have no questions from this presentation, which I will take as a good sign. So if you do have questions, we will be publishing an FAQ in the coming weeks that will kind of address questions that come in as we go. But otherwise, feel free to reach out to support, and we'll get those addressed as best we can. Thank you for your attention, and have a great afternoon.